Welcome to MicroMuster. Today, we are diving into systemic mycosis, important fungal infections for the USMLEs. I'll highlight high-yield facts, key pathogens, clinical features, and treatments to help you prepare. Let's get started with a question and master this topic. A 43-year-old man presents to the clinic with a 2-month history of fatigue, low-grade fever, and a dry cough.
He also reports unintentional weight loss. The patient recently returned from a hiking trip in the Ohio River Valley, where he spent several days in caves known to be inhabited by bats. On examination, he has scattered rails on lung auscultation and mildly enlarged cervical lymph nodes. Chest X-ray reveals bilateral hilar lymphadenopathy and consolidation in the right lower lobe. His serum calcium levels are normal. A serum angiotensin-converting enzyme level is within the normal range.
Given this patient's presentation, which of the following is the next best step?
A. Bronchoscopy with biopsy. B. High-resolution chest CT scan. C. Serum fungal culture for Blastomyces dermatitis. D. Sputum culture for Mycobacterium tuberculosis. E. Urine antigen testing for Histoplasma capsulatum.
Before we attempt to answer this question, let's review the key clinical features of some common systemic fungi, including Histoplasma, Blastomyces, Coccidioides, Paracoccidioides. Now, why are these fungi systemic? How do they spread to cause disease? These are transmitted by the inhalation of fungal spores or hyphae. In some cases, these fungi can disseminate from the lungs through the bloodstream to other organs such as the liver, spleen, bones, skin, or the central nervous system. This ability to spread throughout the body is what makes these infections systemic. The patient usually presents with pneumonia with cough and flu-like symptoms. These can form granulomas and are not contagious, unlike tuberculosis. The severity of the disease can vary depending on the individual's immune status. Immunocompromised individuals, such as those with HIV or AIDS or those on immunosuppressive therapy, are at much higher risk for disseminated infections. Treatment for these systemic mycoses generally includes antifungal medications. For mild cases, itraconazole or fluconazole may be used. However, in more severe or disseminated cases, amphotericin B is often required as the first-line treatment. These systemic fungi have a unique characteristic. They can exist in two forms, depending on the temperature. This phenomenon is called dimorphism. At lower temperatures, these fungi grow as molds, producing filamentous hyphae or conidia. When these fungi enter the human body, which is at a higher temperature, around 37 degrees Celsius, they transform into yeast cells, except Coccidioides, which is a spheruole in tissue. Mold in the cold and yeast in the heat is a useful way to remember this. Let's go over histoplasma first. Histoplasmosis is caused by histoplasma, which is endemic to Mississippi, Ohio River Valley, and Missouri. It is found in soil contaminated with bat or bird droppings. It is also found in bat caves. You may come across the terms farming and spelunking. Spelunking is exploring caves, which is a recreational activity. The yeast form of histoplasma is small, oval infiltrating intracellular form in macrophages. It is smaller than the size of a red blood cell. The mold form is tubular and has branching hyphae with conidia. Clinical signs and symptoms include mucosal ulcers, hepatosplenomegaly, hilar lymphadenopathy or granulomas, and erythema nodosum, which is an inflammatory condition characterized by a formation of tender red nodules or lumps, usually on the shins. Lab tests include urine and serum antigen testing. A chest X-ray reveals hilar lymphadenopathy. A potassium hydroxide culture may also be done, along with GMS or silver staining and PAS staining in order to reveal the yeast form infiltrating macrophages. Treatment is available for both local and systemic infections. For a local infection, fluconazole and itraconazole are utilized, whereas systemically for severe forms of infection, IV amphotericin B may be given. Next, we have blastomycosis, which is caused by Blastomyces. It is endemic to eastern and central USA, the Great Lakes, and Ohio River Valley. Sources include soil and decaying organic material. The yeast form is a broad-based, budding, thick, double-reflecting wall form, which is about the same size as a red blood cell. The mold form is smooth-walled with conidia on aerial hyphae, which you can see on the left. The clinical features include presentation with a pneumonia and a chest X-ray showing patchy alveolar infiltrates or granulomatous nodules. Skin lesions are verrucous or ulcerated, resembling a squamous cell carcinoma. There may be bone involvement as well, which includes osteomyelitis. Lab tests include urine antigen testing along with potassium hydroxide culture for confirmation and a PCR. Treatment again is the use of itraconazole for local infections and amphotericin B for a severe systemic infection. Moving on, we have Coccidioides, which causes Coccidioidomycosis, which is also known as San Joaquin Valley fever. Endemic areas are southwestern USA, California, Arizona, and Mexico. Sources include spores from the soil, especially after earthquakes or dust storms, particularly in arid regions. The yeast form is thick-walled spherules with endospores, which are larger than RBCs, and the mold form is barrel-shaped arthroconidia as seen on the left. Clinical features include San Joaquin Valley fever, which presents with erythema nodosum and dissemination of the infection to the bones, meninges, and skin. Arthralgias may also be present. Lab tests include culture of saliva or blood, along with a KOH preparation, serology testing for IgM to identify acute infection, and a PCR. Treatment again includes fluconazole and itraconazole for a local infection and amphotericin B for systemic infection. Paracoccidioidomycosis is caused by Paracoccidioides. This is endemic to Latin America, Brazil, Argentina, and Colombia. Source of this fungus is soil contaminated with spores which may be inhaled. The yeast form is multi-budding with a staring or captain's wheel appearance or that of a Mickey Mouse. The mold form is Conidia in chains. Clinical features include cough, mucocutaneous ulcers, hilar lymphadenopathy, and chest X-ray showing granulomatous nodules. Lab tests include a culture, potassium hydroxide preparation, serology, and PCR. So it is more or less the same as Coccidioides. Treatment also includes use of itraconazole for local infections and amphotericin B for systemic infections. Here is a summary of the discussed systemic mycosis. Now, coming back to today's question, let's revisit the key patient features. Notice the travel history to the Ohio River Valley and exposure to bat caves, which is a classic risk factor for histoplasmosis. While it is true that some of these symptoms and findings on the chest X-ray, like bilateral hilar lymphadenopathy, can overlap with sarcoidosis, further testing is necessary to differentiate between these two conditions. In sarcoidosis, we typically see elevated serum ACE levels, but this patient's normal ACE levels help guide us towards a fungal etiology rather than an autoimmune one. This highlights why confirmatory testing, such as the urine antigen test for histoplasma, is critical to establishing the correct diagnosis. Now that we have reviewed the features, we can more confidently make the diagnosis and move forward with appropriate treatment. Feel free to go over the answer explanation. Alright, that wraps up today's session on systemic mycosis. Remember, knowing your bugs and understanding their clinical features, transmission, and treatment are key to mastering this topic for the USMLE. Stay tuned for more in-depth discussions on microbiology, and don't forget to like, share, and subscribe to USMLE Drone for more valuable content to help you ace your exams. See you next time, and keep studying hard.